now, I would like to
Keep going, sorry.
welcome my co-host today, Associate Dean of the Faculty of Health Science, Amy Karagiorgakis, as well as our panelists and proud DC alumni, Beth Brannon, Matthew Canning, Tamara Deuce, and J.D. Heffern. Each of these individuals are leaders in their field who have diverse experience in vital areas of the health sector. All graduates of Durham College's Faculty of Health Sciences, they've leveraged their DC education to help shape and strengthen healthcare systems. In addition to students in Lon's Global Leader class, we also today are joined by alumni, community partners, and some students from practical nursing and advanced paramedic programs. It truly is so valuable when alumni return to share their experience with current students. So thank you again to our panelists for being here and engaging in this important discussion about resilience in the face of complex challenges, the importance of equity-centered care, and emerging practices that are really redefining how health services are delivered. After today's Q&A, we'll have a little bit of time to do some networking, so I encourage you all to take that opportunity, connect with the DC team, connect with our panelists that are here today, and engage in some meaningful discussions. Before we get started, I just wanted to say hello to a special couple guests that we have here with us today. Firstly, I'd like to welcome Carol, who's a great friend of DC. Thank you for joining us this morning. And I'd also like to welcome Grace Cannon, who Lon mentioned is up on the screen. Grace is actually a DC grad that happened to reach out to us a couple weeks ago by email to let us know about a remarkable milestone that she is celebrating, and that is 50 years in her career as a registered nurse. Grace is currently working as a registered nurse and learning and development facilitator, where she delivers professional development trainings and opportunities for frontline staff. She's signed in virtually from Alberta, so I believe it's nice and early there right now. So thank you for joining us, Grace, and a big congratulations from all of us at DC on a long and very successful career. I want to invite you, if you'd like, to take a moment to just reflect back on your wonderful career and share a moment that you are most proud of. Can we get Grace up on the screen?
Thank you for having me this morning. I am a proud graduate of Durham College in 1976. Probably for some people in the audience, that's before your parents were born. I spent the first part of my career in long-term care and retirement living for 27 years, and then moved into disability services supporting adults with developmental disabilities. And that field has really evolved in Alberta for sure over the last 23 years that I've been involved. And our individuals are more complex, their needs are greater, and thus the need for continuing ed and additional training for staff is a priority. And I'm fortunate to work with an organization that is a leader in that area. The biggest area of innovation really came for us during COVID, where training needs certainly didn't go away, and our ability to deliver in classroom did. And so our organization developed certainly virtual learning opportunities, but also self-study programming with one-on-one virtual connections for proficiencies, demonstrate skills demos and things like that. We really led the way in that area, and probably one of the most significant things that we've accomplished is to be able to deliver medication administration training for frontline staff in on an LMS platform with online learning, which has been evolving over the last 20 years, but certainly most significantly since COVID. So it's a great opportunity. The workforce is changing. The individuals are changing. They're living longer than ever before. And so it brings in my passions for dementia care and palliative and end-of-life care. So to me, it's the best of all worlds.
Well, thank you so much for joining us virtually this morning and for reaching out. And congratulations again on a successful career.
Thank you.
So let's start off. I'd like to start by inviting our four panelists to begin today. So I'm going to turn it over to you to introduce yourself. So we'll give you each 1 to 2 minutes to introduce yourself, your graduating program, and your year, and tell us a little bit about what innovation and resilience means to you in the context of your work. And I will start with you, Matthew, because you're right beside me.
Thank you. I'm Matthew Canning. I'm a nurse practitioner and the clinical director of the PrEP Clinic, which is a clinic that's located in downtown Toronto with 2 satellite clinics in Brampton and Ottawa. We do HIV prevention and treatment. Our HIV treatment program recently launched in the last couple of years and primarily focuses on uninsured patients. And that's been a great passion because it's been meaning helping people who would otherwise go without care in a world where HIV no longer needs to be a death sentence and people can live long, healthy, happy lives. In terms of resilience and innovation, I think for us, innovation has been born out of resilience. It's been seeing changes into political climates for people for access to healthcare if they're coming as a refugee or if they come undocumented. It's been meaning financial uncertainty or access to finances for folks. And so we've had to create programs that basically didn't exist to help people get access to healthcare. And so I'm very proud to be a part of a team that's able to do that.
My name is Tamara Deuce, and I'm a RN grad from 1993. So I've been around for a little bit. And after that, I did a degree and a master's and have had quite a few different specialties over my career. Currently, I am the Senior Director of Health Services at the University Health Network. So UHN is the largest healthcare organization in Canada. And we have about 44,000 employees, staff, physicians, and volunteers within our team. And I lead the occupational wellness for them. And I got to that point in my career after many years in clinical practice and then as well as in administrative clinical programs, and developed a passion really about the mental health and the well-being of our staff. And how can we keep them resilient and what can we do to help support them? When I took the job at UHN, what I did not know is that COVID was going to happen. And I started in March of 2020 at UHN. So leading the largest organization in Canada and having to deal with COVID. And I mean, I didn't know where the bathroom was. So it was quite interesting, and it wasn't necessarily what I signed up for, but we had to quickly pivot and change everything. We had a massive team of people in the world looking for answers that we didn't know the answers to. So it required us to be innovative, look at what people wanted, what they needed, so that they could take care of their patients, but also then go home and take care of themselves, and in a time of incredible uncertainty. And we changed everything. We had teams come from a variety of different areas, clinical, non-clinical, and pull together and look at what our staff needed so that they could provide good patient care. And it required different solutions that we've never used before. We had to be innovative, we had to be creative, and that's then what supported our staff to be resilient and be able to come in every day during COVID.
Hi, good morning, everyone. I'm Beth Brannon. I'm the Senior Director for Mental Health and Addictions at Lakeridge Health. And I'm super happy to be here with you today. Although I have to say, it's a little hard to say I'm from the class of 94 for registered nursing as well. After doing my registered nursing at Durham College, I did a psychology degree through Trent at Durham, and that was some time ago. And then later on went on to do a master's of nursing as well. And I'm a super proud nurse and a very proud mental health and addictions provider. So being the Senior Director for Mental Health and Addictions at Lakeridge Health means that I have within my responsibility all of our inpatient programs for adults as well as for children and youth, all of our Pinewood Addiction Services, our Durham Mental Health Service, and the Distress Center Durham, which is an amazing training ground for anyone who's interested in volunteering and getting some experience in mental health and addiction. So yeah, it's a very, very large system of care. It's one of the most unique certainly in this province, because all of those things that I talked about, mental health, addictions, inpatient care, emergency mental health, are all very, very connected within our system. And that means that people have to tell their story, hopefully less and less, which is one of the main concerns for many people with mental health and addictions. So if you ask me about innovations and resilience, I think I could certainly lean into COVID. It drove up demand significantly for mental health and addictions. But there's something else that I think has changed societally that I'm really proud of as well. And that's that people will now very openly have conversations about mental health and addictions. I am so proud of our young people in particular who are really open and honest and will talk about the challenges that they've had and open conversations for other people to say, me too. And we're seeing it at rinks. We see it at dinner tables. We see it with our friends, with our families, at a cottage, wherever we happen to be. And I think that that openness has really required the system to respond in a different way, because people are no longer saying it's okay for me to suffer alone and without conversation. I'm going to ask for help. So I'm thrilled that people are asking for help. And I will say it's probably one of the biggest challenges right now is the ability for mental health and addictions providers to meet that demand. There are extraordinary waits in many places, and that can create very significant challenges for people. So I would say that the demand is probably driving the innovation, and hopefully over the course of the next hour or so we can talk about what some of that looks like. And I'm really happy to be here with you today.
Got it. Thank you. Good morning, everybody. My name is JD Heffern, and I'm in a bit of a transitional period of my life. And I recently retired from the federal government as the paramedic chief for the Government of Canada in the Department of Indigenous Services Canada, where I've served for the last 8 years. I was very fortunate enough, and I'm very humbled to say that I was the first paramedic chief for the federal government of Canada, and I learned a lot through that process. But I really believe in mentoring and coaching and moving on to passing things on to the next generation. And so it was time for me to move on to other things. So I do a lot of volunteer work. I serve on several boards of directors. I'm the co-chair of the International Roundtable on Community Paramedicine. I serve on the board of the Paramedic Network in North America, as well as I'm the program lead for the development of the Global College of Paramedics. But in my spare time, I actually still spend time on the road clinically, and I work for the County of Renfrew Paramedic Service, where I've been employed for the last 13 years. And I work as a casual commander on the management team. I still do calls. I still go into people's homes. I mentor and coach our next generation, and I love very much doing that. And when I think of innovation, I think of okay is not good enough, right? Like we tend to just be okay with the status quo and the way things are. And I think innovation is just pushing that envelope to move forward, to do what's right. And in my case, or I think in the case of healthcare, and I think my colleagues would agree, is doing what's right for the people we serve, the communities we serve. And sometimes that's hard, and sometimes people get offended. That's not the way we've always done it. Well, sometimes you got to ask yourself, well, is how you've always done it right? And when I think of resilience, I kind of go to, I don't know if any of you have watched Ted Lasso, right? He talks about the goldfish, right? So if you do a bunch of research on, what species in the world exists after a nuclear explosion. So everybody will say cockroaches, right? But they're not very sexy. But there is another species that does survive a nuclear explosion, and that's a fruit fly. And fruit flies are a little more sexy than cockroaches. And so, as Ted Lasso would say, is resilience to me is be a fruit fly. Be resilient to the challenges that you face. I had to be resilient here. So I graduated from DC in 2013. but I actually started my advanced care paramedic program 2 years earlier because I failed the first time. Right? So I took 2 years to do a 1-year program. So, you know, it's just, it's struggling through the difficulties and pushing forward and pushing forward. And it sucks, but you push forward. And you know, yes, the COVID example is fantastic because we had to be resilient as a country, as a province, as a community. And so that to me is sort of innovation is okay is not good enough, and resilience is dealing with the troubles, the issues, and whatever, and just you push forward. Still am.
Thank you for everyone's introductions. It's obvious there's a great breadth of experience, both speaking to resiliency and innovation within the sector. So we're going to get a little bit deeper with this area. I'll start with you, JD. Innovation can look different across healthcare settings. Can you share an example of an innovative approach or practice you've implemented or witnessed that has had a meaningful impact?
You allowed to pass. I've been very fortunate to work in various sort of environments and theaters, and so one of my roles with the Government of Canada when I went there 8 years ago, really what it was the working with Indigenous populations in remote and isolated communities. We at the time had a 52% vacancy rate of nursing supporting primary healthcare. So if you have ever been to the north in some of these remote and isolated communities, the health center is sort of the hub of the community, if you will. And the healthcare professionals are the hub of the community. So with a 52% vacancy rate, you know, you don't have healthcare professionals there. So that's the problem. So at the time, the Minister of Health for Canada was Dr. Jane Philpott. And so Jane reached out to the paramedic community and said, hey, you guys have had success implementing community paramedicine into primary healthcare. Could we do that in remote and isolated communities? And so that's when I came in, and we started to look at doing the research, the education, the policy development, and the implementation strategy to implement community paramedics providing equitable and accessible care in remote and isolated First Nations that up until that point had zero access to not just emergency response, because, and still to this day, many of our remote and isolated communities across Canada don't have emergency response. They don't have paramedics. And so part of my job over the last 8 years was to change that and then integrate the community paramedics into primary care, which really isn't done. It's becoming more prevalent down this way as of late, and the advent of community paramedicine and the development of community paramedicine, where paramedics go from being reactive and responsive to more proactive and preventative, and being integrated into public health and other realms of healthcare delivery. But I would say, and I don't remember the question now, but because I'm ranting, but I would say that, you know, that was an experience for me, was to go from nothing, where, as I said, okay is not good enough, to create an equitable, accessible healthcare resource for communities that did not have servicing other Ontarians and Canadians in the north using paramedics.
Thank you very much. I'll maybe pass it over to Matthew, continuing from your introduction. A little bit more, if you can provide, about the innovative approaches that you've practiced and the impact that you've seen.
Sure. I thought I was going to be last, but yeah, I think two good examples is if you go to a family practice or a community health center, when patients come in for their visits, they might come in for a concern that doesn't require blood work. But at our clinic, most of our patients require blood work every 3 months or more frequently. When you have almost over 5,000 patients, that can result in lots and lots and lots of blood work reports coming in. So well over 12,000 separate reports coming in that need to be collated, flagged for review, reviewed, and made sure that the patient receives the appropriate care. So with only a staff of 12 nurse practitioners, that can be quite onerous. And our nurse practitioners, I think collectively, are the equivalent to like maybe 4 or 5 full-time nurse practitioners. So we had to think creatively. And so thinking creatively meant expanding what individuals can do or what we think they can do. So administrative team members were not only now flagging for labs, they were being trained to understand what each lab means, what's the significance of it, what the severity of it is, and how to flag it. So now we have an army of admin support who do that, and not just within the technology of our medical record system, but also outside of it. So we had to think, if a medical record system can't do all of that with AI currently, we have to go back to old school paper. So we've been doing really creative strategies to identify these things and create ways for us to manage an influx of patient care. Another innovation that we made, which admittedly I was fearful of, was providing HIV care. So the program alone, being a nurse practitioner outside of an infectious disease clinic in a community, there's often voices that say like, oh, you're a nurse practitioner, you don't have a place to do that independently. You should be doing that with a specialist. But we know that research is moving to show that HIV care is moving into the primary care setting. So your family physician, your primary care nurse practitioner should be able to help you with that, because that's how we'll be able to help more people. That's how we'll be able to make an impact. And so we decided to do that. We did our training. We had our competency. We felt comfortable. We launched it. And then we found that people in rural communities couldn't reach us. So we couldn't help those people. And they didn't have health insurance to be seen elsewhere because they would be paying hundreds, if not thousands of dollars to receive care. So fearfully, we accepted the challenge to do remote calls with these people, which would mean by standard, maybe the care would be subpar what they would receive by an infectious disease clinic if they had access. But we decided that any care is better than no care if the outcome is someone's life. So I provide care with my colleagues remotely to them. We get them their medication. With government-funded programs, we do their blood work, and we liaise or partner with local communities like public health to get them the preventative vaccines they need. And then once, hopefully, with case management and social work remotely, once we can get them some form of insurance, we can get them connected to someone locally. So I think innovation for us has meant facing your fears, doing your research, and then taking that leap to help people. So, yeah.
Thank you very much. I'd like to continue this conversation with Beth. If you can provide a little bit more about the innovative approaches that you've implemented and what the impact's been.
Thank you. So I'm going to lean in, I think, to one theme, but at two different organizations. So one of the things that I am most passionate about is improving access to mental health and addictions care. The wait, I know, for many people can be extraordinarily painful. It can cost lives, jobs, family connections. So making sure that access is as fast as it can possibly be is very, very important to me. And I've had the good fortune at both Ontario Shores Centre for Mental Health Sciences, where I worked for 30 plus years, and then also at Lakeridge Health to redesign what access looks like. And I'll lean into my Lakeridge Health experience, where I started at Lakeridge, and there were waits for many individuals that were in the hundreds of days, and that's to me not acceptable. And I know for many of our practitioners, it also felt really unacceptable. And we had to come up with a different way to think about access, to get people what they needed. I've worked for many years with quality improvement leads. And there's one who I work with on a regular basis, Chris Chadwick, and he has expertise in lean quality improvement methodology. And it's a phenomenal facilitator. So we sat down with a steering team and said, we really need to improve access. We need to make it simple. We need to take accessing mental health and addictions care out of the hands of people who need help and out of the hands of our primary care providers and put it in the hands of the experts. So we brought together a team, and this is what I think is really important in these improvement events. The team consisted of both providers as well as people with lived experience, so our patients and our families, as well as with our partners to say, if we were to imagine what access could look like, what would you want that to be? How would we go about doing that? So, we did a rapid improvement event that was over several days, came up with this beautiful vision of what we thought this could look like. Fast forward 3 years later, most people right now who need help from a mental health and addictions perspective for Lakeridge Health can call one phone number, one team, one door. It's just one access point. And there's a team there that can respond on average within about 3 days. And that doesn't necessarily mean that they're getting to the final care place that they need, but they know that they're getting to the right place with the right match. And for individuals who need it, we put a wraparound care plan around them so that they can have support while they're waiting for that next level of care. So we went from hundreds of days waiting just to get a decision to just a few days waiting. So I'm really proud of our teams. It was very, to your point, unsettling for teams to think about doing things in a different way. And I'm so proud of our people. I'm so proud of our patients and families who joined us on that journey and really demanded of us what they wanted access to look like and what they wanted support to look like. And I think, when you really... Oh, just in case you want to refer to it, okay? Go ahead. Keep going. But I'm really proud of our teams, and I'm proud of the voice of people who said, this isn't acceptable and we need something different. And do I think it's a perfect system today? No. But I think that's what our job is every day, is that continuous quality improvement and leaning into the possibility of what can be better, what can be different, how do we continue to make this better together. So to me, I think if you're thinking about innovation in healthcare, I'll never do it alone. Always do it with people with lived experience, with partners, with care providers. I think we sometimes run into the trap where we think, oh, I know what the solution is. And it's just one perspective. You have to talk to the people who are going to be recipients of that service to co-design together.
So I think innovation thrives when all the people are engaged, but innovation dies when nobody's engaged.
Thank you for the summary there. I'm going to go to Tamara with the experience that you've had and following our panel members. Continuing the conversation with the innovative approaches from your experience.
Thank you. There's been quite a few actually innovative experiences, because I think I don't accept what the status quo is. And I think it is about looking at things differently. As my colleagues have said here, co-designing things, asking people, how can we do better? Asking the questions about why something didn't work. One of the things that often I heard once I went into leadership was, we've tried this before, we're not doing it again. Didn't work. And instead of saying, okay, we're not going to try again, why didn't it work? What can we change? How can we make it work? And what is important to us? So really looking at the system with that co-design look. So what do we want to make it better for the staff? Do we want to make it better for the patients? Do we want to make it better for everybody? How do we pull all of those people together? Developed a lot of family partners in all of the portfolios that I've had when they were clinical, and then now I lead that with staff co-design because my partners are the staff right now in this role. One of the really innovative things we did it was early when the Cancer Center in Durham first opened. That was my first role into leadership. I was a staff nurse, and all of a sudden they said, "Do you want to be a manager?" And I'm like, I don't know. I'm not really sure I can do this. But I took that and I took the years of being a staff nurse, listening to what patients wanted, and really started bringing that towards the leadership tables and bringing the patients in, the patient voice. And what they wanted was care that was connected. They didn't want to be seen as piecemeal. Oh, this oncologist is only going to deal with this oncologist, this nurse, this person. And at one point, we developed this symptom assessment. It was rolled out across the province, but you know, most of the cancer centers had taken it, and it was a piece of paper, and the patients would fill it out, circle all their scores, hand it to the nurse when they come in, and the nurse would kind of look at it and say, "Okay, great, file it away," because that's what they did. And what we did was, okay, let's see how we can use this information, how we can get it even before the person comes in. Of course, for people that didn't have technology or whatever, we dealt with that. We've got kiosks in our lobby. We gave them passwords that they could actually enter this information the day before into their chart. And when they got certain scores, so if their mental health was not good, there was an automatic referral that would go to a social worker. So it didn't rely on the social worker waiting for a referral for a couple of days. We knew that before they even got there, that they weren't going to be in a good space and that they needed help. They needed to see a dietitian, who they needed to see based on these questions. The nurses and the teams could make sure that if they were in uncontrollable pain, that we had a pain specialist and we could facilitate a referral for them when they came in. So we really looked at, because all I kept hearing from patients was, why do I have to keep telling the same story over and over? And why do I have to wait 5 days now? Because I told you my problem for something else. So we took those experiences and we built upon them. And I've used that pretty much in everything that I've continued to do through my leadership, is listening to those lived experiences and trying to create a better system.
I want to build on that. Amy, I'm going to steal your next question because I think it makes sense and flows nicely, because I want to build on that idea of co-creation. So how can healthcare systems better partner with communities, particularly Indigenous or marginalized or underserved populations, to really co-create solutions rather than imposing them?
Thanks. I feel like that's been the theme of what we've been talking about, which is active listening and like engaging in listening and speaking to the community members that should have an active say in how the care is being provided. We're fortunate enough as a clinic that largely serves the LGBTQ population and beyond. And a lot of our team members self-identify or are members. So I think it's important that you as care providers and your team reflects the community that you serve, so that those people feel welcome to share their thoughts, that they feel that they're represented, that they feel it's a safe space, and that you not only actively listen when your patients or community members come in and talk to you about their care, but you will also go out and find ways and avenues to educate yourself, but also to create pathways for engagement and research to provide better care to those individuals. We're currently engaged and have been engaged in research, and we'll be engaging in a new research project that's kind of hush-hush that I'm not allowed to talk about. But, but we're trying to find ways for people who are part of marginalized communities, gender diverse individuals, women, who may not be the first person that you think of when you're trying to get access for HIV prevention or treatment. And maybe that's because of misogyny that's been in healthcare for a long time, and certain individuals haven't felt safe to reach out or have engaged care about their sexual health and beyond. But I think it's important that we not just listen, but we also actively research and try to find solutions that are guided by those patients, um, and kind of put our money where our mouth is in terms of creating those avenues, not just like sitting and meeting and talking, but like creating strategies to improve it long term. That might have been a little long-winded, but I think you got my drift.
Is there something you'd like to give to Delane for the notes? You know, just a few words that you think, the headline, if you will. Sorry, but here comes the hard thinking. Do you want to think about it?
I just think like basically taking an active approach, like not a passive approach, like waiting for someone to come to you to tell
Yeah.
you what their needs are, because they might not feel safe to do so. And creating that open door does. So an active approach to listening, an active approach to research into care for marginalized communities, because the door might not have been open for them before, but it's your job to open the door.
If I said something like passive is not good, is that fair?
Yeah,
I mean, I don't know if that's too blunt.
you could say active over passive role
Yeah.
in engaging with marginalized communities.
Okay, great. Because it's also what, Beth, what you were saying, Beth, yeah, Tamara, you were saying about how you were given a responsibility and you weren't sure you could do it, but you stepped up and you did it, you know, which is great.
And yeah, it's one of those things. Somebody gives you a challenge, or you can either walk away from it and say, "I can't do it," or you can confront it and use those lived experiences that you've had and everybody else has had to promote things, to make things better. And that's kind of always the pathway I've taken. Especially if somebody tells me I can't do something, I'm going to try really hard to do
Yeah,
it.
exactly. Yeah, thanks. Good.
So in my experience, where do we start? So I worked for the Crown, right? And the Crown has done a lot of damage to Indigenous populations over many years.
Yeah.
So the biggest hurdle I had when I started was to build trust. And once you build trust, doors start to open, things start to move. And I remember when I started, I was in Thunder Bay speaking at a health conference with the Anishinaabe Nation, and this lovely, lovely little old gookum, little grandma named Georgina, came up to me, and she said, "JD, I love what you're trying to do to serve our people. I love your goals, the aspirations, and to fill in the gaps in our healthcare provision in all of our remote and isolated fly-in communities. But just promise me one thing." She said, "Do nothing for us without us." Right? And so that, thankfully for me, happened when I started. So then that set the sort of mantra of movement forward. So when it comes to co-design, like, who am I as a white Irish Canadian male to walk into a remote and isolated First Nation and say, "Thou shalt do this," right? And I think, like, I was very fortunate. 26 years ago, my wife and I, for the first 3 years of our marriage, we lived in a remote and isolated First Nation up in Moosonee and Moose Factory on the James Bay coast. And so that helped me a lot in this. The other thing is that I have a colleague of mine, and he used to be the paramedic chief for the Winnebago Area Health Authority Paramedic Service, which services all of James Bay. So it's 6 communities: Moose Factory, Moosonee, Fort Albany, Attawapiskat, Kasheshuan, Peawanuck. And I remember Jeff. Jeff is First Nations. He's part of the Moose Creek First Nation. He's now moved on. He works for Orange Provincial Air Ambulance Service, and he oversees the Indigenous emergency first response teams for all of the First Nations in the North. And Jeff and I worked on a task force together many years ago. And it was fascinating. One time we were sitting in a hotel, and he said to me, he says, "JD, as you're doing things, just remember, we don't want more. We just want the same." Right? Like, and so I was really struck with, yeah, like, just because you live 500 kilometers by an airplane from Thunder Bay, it doesn't mean that you don't deserve the same palliative care access as somebody who lives in Oshawa, right? And so those two things. So Georgina saying nothing for us without us, and Jeff saying we don't want more, we want the same, really, helped me in my co-design, if we want to use that term, of the programs that I was involved in.
Excellent.
Yeah, I think for me, the thing that I would add to what's already been said would be the need for us to be creative. So using approaches where we say, okay, we're going to have a meeting in a room at a hospital or at a conference center, and we're going to invite all these people to come and be a part of providing input. That's a great strategy for some populations. It's not necessarily the strategy that works for all. So, if I think of our Indigenous communities, that doesn't work, right? You have to go to the communities, you have to listen, you have to take time to build relationship and to understand and to deeply become embedded in that community, to understand what that community needs. If I think about our addictions population or our unsheltered populations, asking them to come into places where they felt hurt, mistrust is very, very difficult. So, you have to be very creative in, reaching out and going to welcome centers, going to some of our shelters, finding ways to bring people in. We have through Pinewood Addiction Center, we have a beautiful relationship with Durham College, actually, where we've brought in dental assistant students who can come in and offer some free dental care to individuals who are unsheltered and struggling with addictions, where we know that oral health is a significant challenge. So you have to find really creative ways to bring that voice forward and to meet people where they're at. Whether it's our outreach teams, listening to our paramedic colleagues who are on that front line. So I just want you to think about how you engage those people with lived experience in a different way than what we typically do, which is surveys, meetings in boardrooms.
Yeah.
Right? You have to listen in different ways and bring that voice forward. And be very cautious in our honoring of stories and asking people to tell their stories. Because if you're going to ask someone to tell their story, you better be prepared to do something with that information.
It's very human-centric. It's not tech-centric. What you just said is sort of talk to people, listen to them, meet with them. Don't just put the tech away. You know what I mean? Interact with the humans.
Says the mental health expert.
Exactly. It's so important, at this time of everything has got to be mediated by tech, including this room. But anyways, can we perhaps take some questions from students? Are we okay? Or just area? Or do you want to one more question here and then we'll go to the nucleus? Or are you good? Okay, hold on a second. We'll come for a second, but Elizabeth always has something to say, and you have a lot of experience, and you've brought such resilience to the class. But no pressure, okay? But if you want to, go ahead. Okay, so Elizabeth, please.
Hi everyone. Thank you so much. Couple of questions. So first is a personal one. Each of you seems to have risen in terms of being leaders. But you started as students. Was there ever a time in your life where when you started, you were young and younger, you're already still young, but you were younger and you thought about your lives. Is this where you thought you'd end up? Because leadership, when we talk about leadership, some people think that leadership is something you're born with, like it's a quality that's in you, or is it something that you've developed over time? Like you talked about, you were asked to be a manager and you thought, I don't know, you're asked to step up to the plate, but can you handle it? That's the first part. Second part is, the thing that excites me most is the idea that any service industry is about people, whether it's teaching, healthcare, even creativity. But with the introduction of technology, how are you balancing that? And I have children who look at me and say, Mom, we don't even know what to do with our lives because technology could possibly come and take my job away. So they don't even want to think about serving in an industry where they could possibly lose their livelihood. So how would you address that, as a parent? What do I say to my child? But also just, people over systems. Like systems are there to make things functional, but how do you keep people as the forefront?
Who wants to jump into that?
I
People
can
over
take that one.
systems.
So
Great line.
over
People
systems.
over
You had a few
systems.
questions
Yeah.
there, so I might not answer them all.
Yeah.
But going from student to, again, I didn't have a lot of confidence. I didn't think I was even going to pass all the nursing courses. Like I was like, oh boy, this is harder than I thought it was going to be. And I did it. You continued on. I was not a straight A student. I had to work hard for my grades, and it just kept going back. And I was like, okay, I'm going to get through this. I'm going to get through this. And they're same then when I went on to do a degree and when I went on to do a master's and when I was doing things, I never thought I wasn't even sure I was going to finish them. Sometimes I thought okay, I'm going to quit now. Like this is just too much. And I did I was young. I was 17 when I started in the nursing program. So I was the youngest person there and everybody's looking at me like, she doesn't have a clue. And I didn't. And I don't think I knew what I was going to get into. Never in a million years did I think I was getting into leadership. I just kept taking opportunities and I took challenges that were given to me and always wanted to have a voice at that table. So I think that's what kept me going and didn't think I'd be a director. I didn't think I'd be an all-Catholic. My career has not been planned out at all. And having grown children too, one of them actually, both my kids went to Durham College. My husband went to Durham College, but I've got one now one's done school and the other one is at the university now. And I have the same conversation with them about AI, technology,
Yeah.
where is it going? And I have the same conversation with my staff because we are introducing AI. And it's not meant to replace people. It is to use what is in your head to build those systems. And you know what? All of the AI that we use, even within my portfolio now, we use a lot. And it is about meeting people where they're at so they don't have to tell their story over and over again to us. It is about using that technology to make other people's lives easier, but you can't do it without that clinical background, without the rest of it. So I need the IT people, I need the data people. But they don't have what I have and what my team has and what the nurses, the physicians and everybody else have to be able to build the system. They don't have that information. So we need to work together and we can do that. I don't think it's going to replace anybody. It's just going to make us think about systems differently.
I think that like I probably don't want to go into the nature versus nurture debate, right? So because I think there's evidence on both sides that say that inherently leadership capacity abilities are naturally in some people and in other people's not, but can be learned too. So there is so that aside, I see the power of we talked earlier about the power of stories, right? And obviously my time within Indigenous context. A lot of their generational information is passed down through stories.
Yeah.
Right? And the power of that. And this is actually a whole nother challenge around how do you collect the data from Indigenous populations? Because our researchers, and I'm involved in a bunch of research right now, they want quantitative, qualitative data, but a lot of Indigenous data is like stories. So anyways, all I'd say. So my father was, he was a very successful professional athlete and got into business and we actually had our family had a store up at 5 Points Mall up here in Oshawa at one point. And he used to always teach me was much the saying goes, you are what you eat, but you are the people you spend your time with. Right. So and so for me, as I developed as a leader, I wanted to surround myself with people that are way smarter than me. I still do. When I build a team, I build a team of people that are really smart people that some people in my position would be quite intimidated by, but actually they make me look like a rock star.
Yeah.
Right. And so I want really smart people around me. I want to fill the things that I'm weak in. I want to fill them with people that are strong in. Right. And so and then the other part, to be quite honest, I happen to be at the right place at the right time many times. Right. So, but I think, this is a cliche. If my mother's watching, she's just going to roll her eyes, but because she used to preach this to me when I was a kid growing up and I never listened to her, but you got to read. Like reading is powerful, right? Yeah. Reading is really powerful. So yeah, I think when it comes to the leadership piece and how I got here, there was a lot of right place, right time, but it also was surrounding myself. Like I remember as a student when I did my primary care paramedic training, going to the Ontario Association of Paramedic Chiefs conference as a student volunteer because I wanted to surround myself with all of these really great leaders, right? And just hopefully maybe by some diffusion, be challenged. And I was a decent clinician as a paramedic on the road, frontline. I still am, because I go on the road periodically. I'm okay. I'm safe. I'm not going to kill you. But where I actually was better, and that's why I found where I am, is that I was better in the visionary leadership, the progression of the profession, and our practice, right? So, but yeah. So.
we'll move it around a little bit and see, just to make sure. You'll have a chance to network with them afterwards. But Darrell, Kendra, anything you'd like to say? And then, do you want to could you give the microphone to Kendra? We'll come back, Angelique. We want to make sure. And in the Cosmos, folks, if you want to say anything, just go ahead and put it in the live chat for now, and we'll take it up. Okay? Go ahead, please.
After listening to you guys, I hear a lot of like trauma-informed practice, human-centered care, and it's really great to hear. But my biggest thing is, how did you navigate the challenge from going from a frontline worker to now in this leadership role? How do you continue to use your frontline experience in order to bring the care level that you were able to give as a frontline worker into the leadership roles?
I can answer a little bit of that, but I mean, I think my role might be unique. I started with the clinic as a nurse practitioner and then became the nurse educator and then stumbled into being the director simply from just like seeing a need, filling a need. And then they were like, oh, do you want to do this? And I was like, I don't know if I want more responsibility, but no one else is going to do it, so I'll do it. And there's been push as we've grown that it's expanded, that it was like, well, maybe you should do less clinical hours and less clinical hours and less clinical hours and focus on this. And I've often pushed back gently to say, well, I want to be integrated into the care. I want the patient interactions. I will engage with my team to ask them what they need and practice, reflection and working with them and listening to their needs. But it's also important for me to be boots on the ground. Like, I like the patient interactions because it informs me uniquely on how I can lead better, not just from listening from another person telling me their story, but also experiencing it myself. So I do think there's a benefit of having a leader in a role still doing some of that direct patient care, because it's very different than me just hearing it from a colleague who's sharing their experience. So might not be feasible for all leaders because of, I'm not at an incredibly large hospital that has a lot more staff, but that's one way.
And, I agree. It's about being connected to those, not really separating myself. I try really hard not to separate myself as I'm a leader and you're not. It is about, because I don't think I am any different. I still am a nurse and I still have those core values as a nurse. And I would go in tomorrow and work in a nursing home or anywhere else. Like, I thoroughly enjoy being a nurse. So it's about keeping yourself close to the roots and what you actually want to do. During COVID, all these people went home and nobody wanted to work and everybody was afraid of everything. I'd gown up and I'd go walk into the ICU and ask the staff what they were dealing with. And, again, my focus in that role was about staff. It wasn't as much about patients. I mean, it was about making sure my staff were okay to take care of patients. So it was about patient care, but it really was going out and doing that. And then when I had the emerges in cancer centers and other places, I'd sit in the waiting rooms and I'd talk to patients. I'd sit somewhere and talk to the staff. What is important to them, and not really seeing ourselves as different. I think that's what makes a good leader. Anywhere that you are doesn't matter your title. It really matters about how you relate to people.
Is that good? You want to, yeah, Darrell, anything? You can wait until later. Okay, Waleed, yeah, let's make sure we'll move the microphone around and then we'll come back. And just to be aware, we have about 10 minutes left before we begin the networking portion, right? Okay, and then yeah, sure. Okay, go ahead, Waleed.
Okay, so first of all, great job explaining all of this to us. It was very inspiring. So based on your experiences, what would you say to somebody who wants to continue your fields, like wants to be a nurse or medics? What would you say to them?
Come, Beth, right? Yeah, good. Beth, go ahead.
So first of all, I would say yay. I think.
Before I say, I'm not actually going into nursing, but I just wanted to know. Maybe not. I don't know.
What's good is he's here not wanting to go into this field of health and wellness, but he's come to learn about leadership. That's great, because that's ultimately what this is about. This is about leadership in any field, and you're leading in this particular field. So excellent, you're here. Okay, go ahead, please.
So super happy to hear about anyone who's interested in going into healthcare right now. I think Healthcare in many ways gets a bit of a bad rap for as a profession to go into right now. It's a tough space to be, right? There's, you know, it's a very tight financial time right now for healthcare. You know, we're being asked to serve more with less, and it's a tough space to be. So I'm excited when I hear that people are thinking about that, be it as a direct provider or in leadership. And I wanted to just, you know, really touch on something that I think is coming through from all of us, and I think you were mentioning it, and for you as well. You know, finding that place that puts a fire in your belly makes it really easy to come to work every day, right? So if you can find a way to connect to that passion or to something that inspires you, it makes the hard work a whole lot easier. And I think it also draws people to you, right? Where you can have a common interest, a common passion. And so just be thinking about like what that fire in your belly might be. And it doesn't mean you have to do it in nursing or paramedicine or, you know, x-ray tech or like whatever it is. There is an opportunity to make a difference across the board. So like lean in to that desire to make a difference and really lean into that change you want to see in the world, in our system. There's so much possibility, and I'm so excited for what our youth today are holding in terms of ideas.
Can I play devil's advocate for just a moment? Because often we talk about this in the classroom, about passion. And I will tell students, you have to be passionate and you have to find out what you care about. If you care, you can lead. But then the student will say, I don't know what I'm passionate about. How do we answer that? That's a tough one. What should I, or what should we say to the younger students here who know that, but also don't know exactly where is that fire? How do we get that fire going? Do you want to answer?
Do it through experimentation.
Yeah.
Right? You try different things, and I mean, I don't think to your question earlier, I never went into nursing thinking I would be a leader, right? Like you have to try different things and expose yourself to different things, and don't get stuck in a comfort zone, right? Like step out there, go to a conference, go to speak to people. If you see somebody on LinkedIn and you think, oh, that's really cool that you do that, most leaders will respond and say, yeah, this is some steps you could take. Push the boundaries a bit and experiment, I would say.
We have a couple minutes left. So Amy, maybe I'll pass it over to you to ask
Thanks for
our
that
last question, just to leave some time for.
Go ahead.
Okay. The question that I'm going to go to, I'm going to follow off experimenting, and I'm going to bring this question to Tamara first because it pulls back to one of the themes you started with. Can you speak to a time when a program, model, or system didn't work as intended, and what you learned from that experience?
Just one? I could be here for hours. So a lot of it, most things don't work. I mean, things don't work the first time. And I mean, I've heard examples of Apple, of everything else. Things just don't work the first time. So look at why it didn't work. It doesn't mean it was a wrong concept. It doesn't mean it was a wrong idea. It just means that you might have to alter. You have to listen to your audience. You have to know your audience and who are you trying to make the difference for. And if it doesn't work this way, just, you know, I hate the word pivot, but I'm going to use it. But you just have to maybe slightly change it a little bit and really look at all of those things. Because most ideas, it's just one thing, two things, a few things that just have to be tweaked and altered to make it actually work. And if you're doing it for the right reasons, and I have to, that is another thing, because there's a lot of things that won't work if it's not the right reasons. So if you're doing it if you're just doing it because you got to cut budget, okay, that might not be the right thing to do. But if you're doing it and you're looking at it from the patients, from the staff, from everybody's perspective, and you're all trying to do things, and you just think about what is the art of the possibility here? What can we do with what we have? And you'll learn from your mistakes. You have to learn from your mistakes. If you don't, you'll continue to fail.
Ariel?
Yeah, so I just echoing that. I feel like done is better than perfect. I think we can get stuck trying to make something perfect before we launch a project, and it can delay meeting the need. And I also think just extending grace to yourself and others when you're making changes or planning, because it can get messy and it doesn't always go according to plan. And so Sometimes I think in healthcare we've been taught that it has to be perfect because the outcomes are health, but I mean, still you want things to be safe. But I feel like in most projects that I've ever launched, there's always something we need to tweak or change and reevaluate, and that's a good way to view it.
Yeah, and I could agree more with that sentiment. I mean, thinking of what we've done in the county of Renfrew with the paramedic service over the years, I would argue I'm biased because, I've been there for 13 years, but, we are leading the innovation of community paramedicine development across Canada, if not the world. And it's because of the team. It's not because of me. It's not because of Chief Nolan. It's because of the team. But what we have adapted is you just throw a bunch of crap at the wall and you see what sticks and you build upon it. Right? Like you do what's right for your community. You look at gaps, you do community gap analysis. Where can we use our skill set, our scope of practice to fill that gap? And that's why we created the Renfrew County Virtual Triage and Assessment Center, where any unattached patient to primary care within the County of Renfrew can call a 1-844 number, talk to a medical assistant, get an appointment with a nurse practitioner, a family doctor, or a community paramedic to visit their home. Right? And now we've got a $4 million a year sustainable funding from the province. And why did that happen? We threw a bunch of crap at the wall and saw what stuck. Right? So you're right. It doesn't have to be perfect. And in the world of quality and improvement and all this stuff, there's this whole PDSA cycle thing, right? You plan, you do, you study, and then you act upon it, right? And that cycle is cyclic. So if you Google and look it up, it looks like a circle, and that doesn't end, right? Because you keep building upon your failures or your challenges, and you build upon your successes to make things better. That's the whole, important part of quality improvement. You want to improve on the successes, right? So.
Yeah, I agree. I think you said to me, what's one? I could give you 100 examples of where we've tried things and they haven't worked. But what I would say, maybe that's in addition to what everyone has already said, because I don't want to repeat, is the importance of curiosity and leaning into that curiosity, right? Sometimes people have good ideas. Sometimes people have wonderings. Put it out in the world. It can be a bit vulnerable sometimes, but put your ideas out there. Ask the hard questions, right? Don't be afraid of that potential failure. From it, you grow, you learn, you pivot.
It's a good word.
I know. I think it might have got overused during
Yeah,
your
exactly.
time.
It's a bit overused, but
Yeah, like be curious.
Yeah.
And I love what you said about offering yourself grace. Right? No one's perfect. No one has all the answers. No one knows all the plans. Offer yourself the grace to be a learner and to be curious and put yourself out there.
Well, thank you. I want to wrap us up by just saying thank you to the four of you for coming back to Durham College. I know it's been a while since you guys have been on campus again, so it's always a pleasure to have you back. But thank you for sharing your thoughts, your insights, being real and honest, and just sharing your lived experiences with us today. So thank you for that. Just a couple other thank yous before we wrap up. Thank you to everybody who's here in the audience and for your engagement today. I think it really made for a meaningful conversation. So I want to leave a couple minutes at the end for everybody to be able to come up and interact and ask any questions you may have. But also thank you to Lon. Thank you to Grace, who's online, for joining us bright and early. To Sally, of course, for all of the coordination that went into this, and all of the advancement and alumni team for everything that went into planning this. So enjoy. We've got about 15 minutes left for conversations to continue. And again, thank you all so much for being here.
Thank you.
And if we could grab a quick group photo before everybody heads out, that would be great.
Okay, I'm going to mute, but we're going to still be on YouTube just visually. So people will see a lot of mingling here, but here we go.